So I'm now extremely privileged to welcome our next speaker. Dr Charlotte Tottman is a clinical psychologist who owns a private practice specialising in the treatment of cancer-related distress. Dr Tottman treats cancer patients, their family members and carers, including both adults and children, at all stages of their cancer experience. Dr Tottman also lectures in postgraduate clinical psychology at Flinders University. Please help me welcome Dr Tottman.
Hello. My very important prop. I'm going to have to put it on the ground. There's a reason for that. Okay, so my name's Charlotte Tottman. I'm a clinical psychologist. I see cancer patients, their family members and carers all day, every day. That's my job. It's a very privileged position that I find myself in. Some psychologists say, why do you want to do that work? And I say, well, my patients don't want to die. So it's a bit different to a lot of psychologists. It's really good work. It's me. I'm going to talk to you about 3 things tonight. I could talk probably all night, so I tried to get it down to 3. Feelings of isolation, fear of recurrence, and setting your agenda. There's one topic that I thought about talking about, which is sexuality and intimacy, which is a big one. But if I talked about that, I wouldn't be able to talk about anything else because it's quite a big one. So in the event that any of you do want to listen to me for 16 minutes, you'll never get back, you can look on the Cancer Council website and there's a sexuality and intimacy video of me talking about that, and it might be useful. I do recommend it to quite a lot of my clients. The reason I'm not talking about it tonight isn't because it's not important, it's actually because it's so important, okay? So when people are diagnosed with ovarian cancer, like a lot of other cancers, they report often feeling blindsided. Even if it's been a long diagnostic process, even if they've had a hint that maybe something isn't quite okay, even if they've got a clue that it's cancer, they often still report feeling blindsided. There are those words at that moment in time where the doctor tells them it's cancer, and often people report not really hearing anything that comes after that for about 15 minutes or half an hour, and they go home and say to their husband, I know, I saw the doctor's lips moving, but I don't actually remember taking anything in. Information processing takes time, and everybody processes information differently. Sometimes it takes minutes or hours, even days, and partners process information at different speeds than one another. So it sets up difficulties right from the beginning. People start to process the immediate and future implications of their diagnosis, and with ovarian cancer, that can be pretty serious. I deal with a lot of people I call the sandwich generation, and I see that sort of demographic in this room tonight, and that is that people are often diagnosed at a time in their life where they're dealing with other big family stressors. They often have children, and they often have ageing parents, and their cancer is just one more thing that they have to deal with. And the stuff that they've got going on with children and the stuff they've got going on with aging parents doesn't just go away just because they've got cancer. So it's a whole lot of stuff happening all at once. And so what we see, not surprisingly, is an increase in overall stress levels. And that's often why people come to see me. Not because they've got clinical depression or clinical anxiety, although that does happen, but often because they're stressed and they need some help to figure out how to manage that stress. So I tried to think about what's a bit different about ovarian cancer compared to maybe some of the other cancers that I do work with. And I guess what I came up with is that it has a lower profile. Yes, we're wearing the ribbons, and yes, there are fundraisers, and it's getting a bigger profile, but we'd be kidding ourselves if we said that it had the same profile as, say, breast cancer. It's not the pin-up girl for cancer, okay? It doesn't have a good reputation. When people talk about ovarian cancer, they talk about it in hushed tones, they talk about it with drooped eyes, they talk about it, as if it's a serious thing, and that's because often it is. There's less education around ovarian cancer. A lot of people don't know much about ovarian cancer, and it's about your girly bits, so they don't ask about ovarian cancer. They often don't want to go there. The symptoms, as you are aware, are often nebulous, and so that often means that things are not picked up until late, when things really are serious. And that's very different to a lot of other cancers. So it's not a same situation as, say, breast cancer. It's not a same situation as, say, even, well, I could go on and on, lots of other cancers. Feelings of isolation can best be summed up by people saying to me they don't get it. And that can be family, it can be friends, it can be colleagues. And it's that feeling that they're going through something incredibly intense, and even though they might be surrounded by people who really love them and care about them, if those people haven't been through a cancer experience, not through any fault of their own, they can't get it. And so they might experience sympathy, but they won't get empathy. And empathy is what is really gorgeous. I say to people, if you can get empathy, it's like gold. Yeah, that's what we want. The sorts of strong negative emotions that people feel are shock, fear about starting treatment. Usually what I see when I'm dealing with clients just before any new treatment begins is an uptick in their anxiety. They haven't had surgery before, or they haven't had chemotherapy before they start it, we really see a little uptick in their anxiety. It's completely understandable, because what we know is anxiety rises with the unknown, the unfamiliar and the uncertain. So you've got all of that going on when you're about to enter a new treatment phase. Anger, often anger and injustice, a real sense of like, this isn't fair, why did this happen to me? Anger sometimes at a long diagnostic process, anger sometimes about the way the medical system works or doesn't work. Sadness, which is about the loss of activities, the loss of income, the loss of work, the loss of sexuality. Also sadness about maybe the upcoming loss, the idea that I might not live as long as I thought I would. And guilt. Mother guilt's a whole thing, yeah? Women are really good at mother guilt, and it gets inflamed around a cancer diagnosis because people feel guilty about their illness impacting other people's lives. I've had 2 women in the last week come in and say, I feel so guilty. I've got one daughter getting married and I've got another daughter having a baby, and my illness is getting in the way of their significant life events, yeah? Emotions are driven by thoughts, okay? So I use a framework called CBT, which stands for Cognitive Behavioural Therapy, and the principal idea behind CBT is that we all have thoughts, we all have feelings, and we all have behaviours, and they're all different things. And the idea behind cognitive behavioural therapy is that thoughts drive the feelings and feelings drive the behaviours. So when we have strong emotions, what I look for is what are the thoughts that are driving those strong emotions. So if we look around the fear, what are the sorts of thoughts that come to mind? And typically they are, what if the treatment stops working? What if the cancer comes back? What if I die? So these are big, fat thoughts, yeah? It's not surprising that they provoke really strong negative emotions. Anger thoughts, it's not fair, that sense of injustice. Why me? I think it might be Ganeshan, but there is one oncologist, and I quote them often, without knowing exactly who it is, who quite often when patients say, well, why me? They say, well, why not you? And that's that random thing, yeah? What about I did everything right, you know? I lived a good life, I ate all my green vegetables, I exercised, I didn't drink, and still I ended up getting cancer. And other people don't understand. I'm going through this incredibly intense experience and the people around me just don't get it. I had one woman say that the only time that she felt like her friends got it was if she was lying on her couch with her head in a bucket. And she didn't want to have to do that just so her friends would get it. The sadness thoughts, I've lost so much has been taken away from me. My life is not the same, and life is not the same. I quite often draw a diagram on a whiteboard which looks like a crosshairs, and the bottom line is your lifeline, and the middle line is the moment of diagnosis. And the idea is that at the moment of diagnosis everything changed. And my way of thinking is that moment of diagnosis leaves a mark on your lifeline like nothing does. Nothing is ever quite the same. Most people can remember the date of their diagnosis. It's like B, D and AD, yeah, before diagnosis and after diagnosis. And I may not live to experience important events. Again, that real sense of like loss, anticipatory loss we call it. And guilt thoughts, it's my fault, yeah? Somehow I brought this on, yeah? And I'm a burden. So I'm now someone that my family have to care for instead of the woman typically taking the role of carer and protector and organiser and chauffeur and, you know, all of that stuff. But then finding themselves being the person who needs to be taken care of. They mightn't be very good at asking for help, and they mightn't be very good at accepting help. So on to fear of recurrence. Fear of recurrence is a big thing, okay? The stats around fear of recurrence are huge. I don't think I've seen a bigger stat than this around psychological stuff. So 70% of people who go through a cancer experience fear of recurrence. So what that says is it's pretty normal, it's pretty common, but it's not very nice, okay? The sorts of triggers that trigger that fear, when you've already got it, so you've got the fear after diagnosis, but it can really get triggered and fired up when someone you know is also diagnosed, because it brings it all back. It's like, I remember that, yeah, and it can happen to others. It's not just me. Medical reviews. So when people go through treatment and then they're in a post-treatment phase, often they've gone into a review protocol, which might be every 3 months or 6 months or 12 months. And often that requires tests, sometimes not. But usually what we see is in the couple of weeks before a review, a real spike in anxiety. And what I say to patients is, basically, you're going to have to endure that next couple of weeks. And when you sit in front of your oncologist or your surgeon and you hear the news, even if it's not good news, at least it will be certainty. It will be more information than you have now. And that fear and that spike in anxiety will come off the boil. And if it's good news, it'll be like someone popping a balloon. And the other trigger is physical symptoms. Now, when I talk about, I'll come back to the physical symptoms. So review anxiety is what I was talking about before in terms of medical appointments. Increases in the lead up to a review appointment, and it's highest between having scans and bloods and actually seeing your doctor. So if you have your scans and bloods or any sort of test done on a Monday and you're not seeing your doctor for another week or 10 days, that's obviously going to be a pretty miserable time. So what I say to my patients is, if you can, wherever possible, try and get those appointments as close together as you can, so that you're only suffering with that uncertainty for as short a time as possible. Fear has a bad reputation, yeah? Lots of people have the idea that like anxiety is a bad thing and we should get rid of it. I don't really subscribe to that. I think that fear is your internal burglar alarm. It's the thing that keeps you safe. It's the system that makes you step back off the road when there's a semi-trailer bearing down on you. It's the thing that made you go to the doctor in the first place. So we don't actually want to turn off your anxiety system, but like Goldilocks, we don't want too much, we don't want none at all, we want just the right amount. And the problem with fear is that it can become paralysing. It can become absolutely overwhelming. And that's not what we want. I'm just going to do a quick fear exercise with you. Now, I'm not a very Zen psychologist, like I'm not touchy-feely. You can probably tell by now I'm pretty direct. But this is one exercise. It sounds a bit weird, but it's actually been really helpful for a lot of clients. So I want you to do it in your head, or not do it. You can just sit there and have a snooze. Doesn't matter. But I want you to think about if you've experienced fear of recurrence, and for those of you who haven't had a cancer experience, you might want to think about a fear of something else. But I want you to think about that fear, and I want you to think, what colour is it? Okay? And then I want you to think, what shape is it? Is it a shape like a defined shape, like a sphere or a cube, or is it something more kind of lumpy and nebulous that doesn't have a defined shape? And then I want you to think, what is it made out of? Is it something like soft and furry, or is it something like rubbery? I want you to think about how big it is relative to the size of a house. Is it as big as a house? Is it as big as a car? Is it smaller than that? I want you to think about how heavy is it if you tried to pick it up and you tried to move it. Like, could you pick it up? Would it be light and wispy? Can you see through it, or is it opaque? What's its texture like? So if you ran your hand over it, would it feel like rough, or would it feel like really smooth, or would it feel spiky and jagged? And if you pushed into it, could you push into it, or would you get resistance? So one client I did this with last week, her fear was green, it was slimy, it was a big sphere, it was bigger than a car but not as big as a house. It was heavy but not so heavy that she couldn't pick it up, and if she pushed into it, it would give a little bit. Now, the reason that we do this exercise is to objectify the fear. We turn it into a thing that you can literally see in your mind's eye. And the reason behind doing that is that once you turn it into an object, you can do something with it. You can sort of set it aside. You can say, okay, I know you're here, you're part of my life now, but just because you're here, I don't have to engage with you all the time. I can pop you over there and I can come back to you when I'm ready, because you're a big green ball of slime and you're not going anywhere. And just being able to get that objectivity and that distance from it can stop the fear feeling completely overwhelming. Often when people feel a strong emotion, they feel like they really can't get out from under it, like it becomes part of who they are. So being able to get a bit of distance from the fear, it can be quite useful. And there's a second step to it that sounds even weirder than that, and that is you can give the fear a name. If you're going to give it a name, pick a name you don't like. A very wise oncologist once said to me, it doesn't really matter if you've got the fear, it's like what you do with it. So I talk about fear as a motivator. And you can use fear as a motivator to engage in healthy behaviours and to live your life consistent with your, and I'm going to talk about this in a minute, redefined values. So you can make the fear work for you. And that's much better than being paralysed by the fear. This is the physical stuff about recurrence. And what often happens with fear of recurrence is we engage in a cognitive activity called body scanning, which is like we do a mental check about what's going on in our body all the time. We don't even realise we're doing it. And we pick up any signs that something isn't quite right. And when we pick something up, the first thought is the worst thought. And it's cancer, it's back. And what I try and get people to do, and this is the thing I have to be careful with, particularly around ovarian, is I try and get people to think of other explanations. Now, that's tricky because with ovarian cancer, the symptoms can be nebulous and recurrent stuff can be nebulous. And I can't tell you it isn't recurrence, and I never say it isn't recurrence. What I do try and get people to do is to just consider whether there are other explanations. If you stick with the first thought is the worst thought, it's like you put 100% of your eggs in that basket. If you try and come up with a couple of other explanations, it's like you divide that basket of 100 eggs into a couple of baskets, yeah? And that can take some of the heat out of it. I said before that empathy is great. Empathy is really good in terms of managing fear. If you can talk to somebody who gets it, it can validate and it can make you feel like what you're feeling is completely reasonable and understandable. It feels like they get it. People who don't engage in empathy tend to either dismiss or challenge or try and fix it. And none of that's necessarily helpful. A word of caution about empathy is you just need to be careful that you don't take on another person's experience as your own. So even though you might talk to somebody who's had a cancer experience, you want to take the good bits of their empathy, but you don't want to buy into the fact that just because certain things have happened to them, that they will necessarily happen to you. Setting your agenda. So that's all about taking control of your life, setting goals, making positive and helpful choices, knowing yourself and acting on that knowledge. This is my analogy. So you've probably all seen a little snow globe at one time or another. I need a bigger one for these talks. So the idea is that this is your life. When you get a cancer diagnosis, it does that. It shakes up your life. And all the little snowflakes in there are your values and priorities. And when they settle, none of them settle in exactly the same place they were before. So some of the stuff that didn't used to matter matters, and some of the stuff that did matter doesn't matter anymore. And so I guess the one thing I do see, if you can take any positive out of a cancer experience, is that people tend to redefine what matters to them. They get increased clarity around the stuff that matters and the stuff that doesn't, and they have an increased willingness to prioritise their own needs. So they do the stuff that works for them. Last two slides. Coping psychologically, what sometimes doesn't help, positive pressure. Lots of people saying, think positive. Yeah, we're going to fight the fight. I don't engage in the fight at all. And you look great. Like, well, of course I look great. It's taken me 20 minutes to look like this, but you haven't seen me when I go home and, really fall apart, yeah? And I don't want to have to not look great in order for you to actually understand that I'm not feeling great. What usually does help? Expressing. So getting stuff out, talking about stuff, writing stuff down, better to get it out rather than internalise. Empathy, I've talked about that. Exercise, annoying but true. And activities with purpose and meaning. One of the things that happens with a cancer diagnosis is often a lot of the stuff that we really get value out of in our lives is compromised. It's either taken away or it's compromised. Getting back to activities with purpose and meaning is really important in terms of coping psychologically. I'm done.
Thank you very much, Dr Tottman, for that extremely interesting and very engaging presentation. What a great insight into the psychological impact of cancer.